So thank you very much. I'm not going to go into too much detail about the specific management of high blood pressure in the postnatal period, but I'm going to focus more on rather the implications of hypertensive disease in pregnancy in the postpartum period and beyond. Now, just jump ahead. Hold on, that's not working. Oh dear, sorry. My slide isn't going ahead here. Oops, there we go. Yeah. Sorry, there's just a bit of a delay, I think. So you may have heard it been said that there's no cure for preeclampsia apart from the birth of the baby, or more specifically, the placenta. And although technically this is true, the problem with that statement is it suggests that once the baby is born, the risk just disappears. And as Anja's already highlighted, that's certainly not the case. So most cases of hypertension in pregnancy do tend to settle after the first week or so, but it can persist, it can get worse, and it can present for the first time in the postnatal period. And it's been estimated that over a quarter of preeclampsia cases present for the first time postnatally. And in most of those sort of postnatal presentations, it's often after the woman's already been discharged from hospital and gone home. A significant proportion of eclamptic fits can happen postpartum. Most are within the first 48 hours, but they have reportedly occurred up to 28 days postnatally. And most of the women who die from hypertensive disease in pregnancy die in the postnatal period. And maternity investigations over the years have found that in the majority of those cases, that the cause of death was due to treatable pathology, and that substandard care was a significant feature. So not recognizing the severity of the problem early enough, not acting quickly enough, and or appropriately enough. And they really highlight the importance of sort of early recognition, management, and escalation of care. And just to give you an example of this, this is a vignette that was taken from the 2019 Embrace report, and it tells the story of a healthy woman with a low-risk pregnancy. She gave birth on a midwifery-led unit. Following the birth, she developed a severe headache and moderate hypertension. She was prescribed opioid analgesia for the headache, and it was a verbal order, so she didn't see a doctor. And over the next 3 hours, she developed severe hypertension. But she wasn't transferred to the obstetric unit until she lost control, until she started showing neurological signs. And when she got to the unit, she had lost control of her airway. And when they did a CT scan, they found that she had had a large intracranial bleed. So it really just kind of highlights the importance of not being complacent in the postnatal period, even if somebody has been presumably low risk up to that point. And it's really important as well that women are made aware of the risks postnatally as well, because a lot of women aren't aware that they're still at risk after the baby's born. And in the postnatal period, it can be quite difficult to sometimes pick up on the symptoms. It's quite easy to put the symptoms of preeclampsia down to other causes, just having had a baby or recovering from the birth, etc. And this is just another testimonial that I got from, it's an online testimonial that was shared. And this woman says, 4 days after being discharged, I had severe swelling on my limbs and genital area, as well as an unbearable headache, which was high blood pressure, but I didn't know it then, nausea and vomiting. So classic signs of preeclampsia. I took a nap thinking that would cure the headache, yet when I woke up at feeding time for my baby, I realized I was so confused and had altered consciousness to the point that I could not get off the bed because my brain was doing other movements with my limbs. After that, I don't remember anything, and my husband claims that's when I went into seizures. I had continuous seizures and was in the ICU 11 days. It's been 7 years since the episode, yet my husband and I are still traumatized and scared to try for another. Any woman that's had high blood pressure in pregnancy or in labor, even if, say, she had an episode of hypertension and only needed one-off medication for it, she should still have a postnatal care plan when she goes home that outlines the care that she should have, the ongoing care, who will provide it, and when she will get it. And as I mentioned, women should also be made aware of symptoms and signs to look out for and who to contact if they have any concerns. And if the women are monitoring their own blood pressure, It's important to make sure that they've got a monitor that is validated for use in pregnancy and pre-eclampsia, that they know how to take an accurate blood pressure, and that they know what the thresholds are and what to do if they have an abnormal blood pressure. And even if you don't offer home blood pressure monitoring as a service, it's important still to check with women, ask them if they are home monitoring, because a lot of women are doing it sort of off their own backs now. But surveys have showed that most don't tell their healthcare professionals about it. And then it's also really important that the women are given an opportunity to discuss what happened, to debrief after. A lot of women who have had preeclampsia or hypertension in pregnancy describe the experience as being quite traumatic. Even if it hasn't been quite as dramatic as that example I gave earlier, it can come on quite suddenly. It's quite a difficult disorder to understand. It's quite complicated. It can be very unpredictable. And, you know, these women can be very unwell. Their babies can be very unwell. You know, they're often separated from their baby. They can be separated from their babies if they're in special care. If the women have had severe hypertensive disease in pregnancy, or if the onset was preterm, then that debriefing really should be with a senior obstetrician. And ideally, it should occur at a time that's of their choosing. So a lot of women say that when they're being discharged from hospital, it's still a bit too soon, that it often takes time for the dust to settle and just to kind of get their heads around what happened. Although I'm not sure how many have that opportunity necessarily to come back later. And then the women need to be counselled as to their risk of developing hypertension in future pregnancies, and as well as the implications for their future health. Now, in terms of future pregnancies, the risk of recurrence will vary depending on the severity, the type of hypertensive disease in pregnancy that they've had, and the severity. So, for example, a woman who has had, say, severe preeclampsia that onset, 28 weeks is going to have a significantly higher risk of recurrence than, say, maybe a woman who has chronic hypertension or a bit of gestational hypertension at the end of her pregnancy. But overall, the risk of recurrence is estimated to be around 1 in 5. And that risk of recurrence increases quite significantly if there's an interval of more than 10 years between pregnancies. So all women who have had hypertension in pregnancy, if they get pregnant again, they should take aspirin from 12 weeks onwards to help reduce the risk of it happening again. Now, these women are also at increased risk of cardiovascular disease in the future. So, for example, they're 5 times more likely to have hypertension, and we're not necessarily talking decades down the line either. A third of women who have had hypertensive pregnancies will require blood pressure medication within 10 years of that pregnancy. They're up to 4 times more likely to have a stroke, and they're twice as likely to have a major cardiovascular event or to die of cardiovascular disease in the future. And the babies of these pregnancies are at risk as well. So we don't have as much evidence looking at the longer term outcomes for babies, but the evidence that we do have shows that they're more likely to have structural differences in the heart, that they are more likely to have higher blood pressure relative to their peers in childhood and adolescence, and that they're at an increased risk of developing hypertension or suffering a stroke as adults as well. And these risks aren't the same for everybody. So, for example, people from certain ethnic backgrounds or people living in areas of higher deprivation, for example, are more likely to get these disorders, hypertension in pregnancy and cardiovascular disease, and they're more likely to have poor outcomes. Now, the postnatal period has been recognized as quite an ideal opportunity to help mitigate these longer term cardiovascular risks. So, for example, researchers in Oxford, Alex Cairns, Jamie Kitt and Paul Leeson, found that during the postnatal period, when the mother's cardiovascular system is returning to its pre-pregnancy state, that home blood pressure monitoring combined with personalized titration of blood pressure medication significantly reduced the woman's blood pressure and improved her cardiovascular function, both in the shorter term, so up to around 6 months, but also the longer term, so 3 to 4 years down the line. It also significantly reduced the amount of blood pressure medication that she needed to take. And the improvement in blood pressure that was achieved through this intervention equated to a 30% reduction in future cardiovascular disease risk. So that's quite significant. And then, of course, we know that healthy diet and exercise are linked to cardiovascular risk. And in theory, during the postnatal period, we have more opportunities to support families with this, just through increased healthcare contacts. I say in theory, though, because that relies on a well-resourced maternity system. And we all know that when staffing is tight, that postnatal care is usually the first casualty. Having a baby can be a catalyst for making healthier lifestyle changes. And then breastfeeding as well is associated with both reduced risk factors for cardiovascular disease and improved cardiovascular outcomes for both mothers and babies, independent of lifestyle and socioeconomic factors. So there's a lot of interest at the moment in looking at how we can really sort of exploit this opportunity and make the most of it, and hopefully alter the health trajectories for these women and babies. However, most of the strategies that are currently being looked at place all of the responsibility on the mother at a time when she's got quite a lot going on. And this is particularly relevant for underserved groups, women who are sort of facing other challenges, who are going to be at higher risk for getting these disorders and may face more barriers in terms of engaging in these strategies. So just to give you an example, there's quite a strong link between trauma and cardiovascular disease risk. So people who have had traumatic experiences during their childhood are up to 50% more likely to develop cardiovascular disease in the future. Emotional stress, mental ill health, poverty are all linked to an increased risk of hypertension in pregnancy and future cardiovascular disease risk. And then during pregnancy and the postnatal period, things like abuse, domestic abuse, mental ill health, poverty can all escalate. So you can see how if we're not careful, if we don't take these factors into consideration and we just kind of go charging in saying, right, I think you should lose some weight so you don't get cardiovascular disease in the future, we could potentially be, investing in strategies that just don't work or even causing harm. And that's really what I'm focusing on with my PhD research. So exploring the postnatal experiences of underserved women who have had hypertensive pregnancies to try and get a better sense of what sort of challenges they're facing and what their information and support needs are, hopefully with the idea to be able to then use that information to develop a complex postnatal intervention to help reduce those longer term risks. Now, there are two other really important factors that we need to consider when we're thinking about hypertension in pregnancy and cardiovascular disease risk, and that's air pollution and extreme temperatures, heat waves. Both are risk factors for hypertension in pregnancy and cardiovascular disease. In fact, air pollution is one of the major risk factors for cardiovascular disease, and 99% of the world's population are exposed to higher levels than we should be. And both within the UK and globally, it's people living in poorer areas who are exposed to the higher levels of air pollution. So real disparities in terms of exposure and risks. And air pollution crosses the placenta, it gets into breast milk, and of course babies breathe it in through the atmosphere. And both air pollution and these extreme heat events are increasing because of global warming. So, if we're thinking about how can we reduce these longer term cardiovascular risks, these are quite important considerations, which potentially could derail our efforts. They are significant potential confounders, and yet there's very little awareness among stakeholders. So healthcare professionals, parents, researchers, etc. So I think we do need to sort of really be monitoring this more and raising awareness about it when we're thinking about these risks. And then other gaps in evidence. We don't have great data on postnatal blood pressure outcomes, really. I mean, we're all right at reporting on hypertension in pregnancy and in labour, but once the women are discharged, we don't have any sort of routine mechanisms for reporting hypertension. And we still don't actually have great evidence on what's optimal management of hypertension in postnatal periods. So what are the best medication dosages and combinations, etc., particularly for women who are breastfeeding. And then we don't have any research on effective lifestyle and breastfeeding strategies for this population. So women who have had hypertensive pregnancies do often face additional barriers to breastfeeding that can make it much more difficult. I mentioned air pollution and heat waves. We also need more research following up the longer term outcomes of these mothers and babies, particularly for babies who have been largely overlooked in terms of the risks. The NICE guidelines on hypertension in pregnancy say that we should counsel women on their future cardiovascular risks, but they don't mention the risks to the babies at all. So we really need some prospective longitudinal cohort studies. So just to summarize, hypertensive disease in pregnancy can persist, it can get worse, and it can present for the first time in the postnatal period. So it's really important not to be complacent. And these women and babies are at increased risk of developing cardiovascular disease in the future. However, the postnatal period does sort of offer us this quite unique window of opportunity to try and mitigate those risks. But we need more research really to understand how best to optimize that opportunity. And then we really need to be sort of addressing and monitoring those environmental risk factors for these disorders. And that's it. So thank you very much.